team. And I'm excited to be presenting some ideas and mostly leading some discussion with you all today on this topic. And I also have with me my colleague, Brooklyn Nelson. Brooklyn, if you're available, would you like to briefly introduce yourself?
Sure. I am a clinical pharmacist with Ballad Health Medical Associates in kind of the East Tennessee region, and I'm also co-funded with ETSU College of Pharmacy as well.
Right. Well, thank you, Brooklyn, and truly, all gratitude goes to Brooklyn for providing some kind of backbone information that we're going to use to go through this topic today. But I'm going to get us started off. So, as Alicia was saying, we're talking about some care team member integration within workflows and a discussion of some best practices in that. And so we're going to look at some examples from some of our member practices, talk about a patient story, and then hopefully get some good discussion going about what you all are seeing or struggling with in your own practices. And there we go. And so really not much more for me to say on this slide, really. We're talking about workflow integration. As mentioned in the intro, we are both pharmacists by training, and so that's primarily where our perspective is going to come from. But we hope to bring up some topics or some lessons learned that can apply across all sorts of care team members. And so another important team member through the Heart Health Network work that we're doing are the health coaches. And some of you on may be involved in training or preparing health coaches through that toolkit. And so really, I think a lot that we're talking about, even though it might start from the pharmacist perspective, it's things that go across the entire clinical workflow. And I think there can be some benefit and some discussion from all sorts of perspectives on that. All right, so I'm going to hand it over for a few slides for Brooklyn to share some information about her practice. And Brooklyn, you can just let me know whenever you want me to advance slides.
Sounds good. Thank you. So I created this slide set kind of to give a background into what our program has looked like before we started with the Tennessee Heart Health Network, and then kind of what it's been since then in the last 2 years. So right now we have several pharmacists in our Tennessee market. We also have an additional 4 pharmacists in the Virginia market as well. Most of the ones listed on here have completed 2 years of residency in the ambulatory care setting. In 2020, it was in 2020, we had one pharmacist that transitioned from this kind of practice-based model where the pharmacist and physician or nurse practitioner all work kind of in that same practice to having a specific quality metrics coordinator. That's kind of, she is the filter that all of the payer data comes kind of to her for any patients that need to be on statins, any patients that have an A1C above 7, or that aren't meeting their adherence goals and things like that. And then she kind of filters that out back to the practice-based pharmacist. So Alicia White has been our quality metrics coordinator for the last couple of years and really helped us integrate our payer data into the practice level and in places where we have those strong relationships built with the providers that we work with. Typically in our model, most of the pharmacists I would say work with somewhere between 8 to maybe 15 providers, depending on, kind of what the level of experience is with the providers and what their patient panels look like. So patients who typically are a little bit more complicated or a higher percent of Medicare and Medicaid population may utilize a pharmacist a little bit more than our providers that may have smaller patient panels or maybe more of a commercial patient population. Can you go to the next slide, Carrie Lynn? Thank you. I forgot I don't have that control. I was clicking my button. Okay, so what we've been using over the last few years, so our first pharmacist started kind of at the end of the last quarter of 2015. So we started tracking really our interventions starting in the calendar year of 2016. And our team has grown by one pharmacist about every year. In 2021 and 2020, sorry, 2020 and 2021, we actually hired 2 to 3 pharmacists. So that's why you're seeing that growth escalate very quickly over the last couple of years. So the program that we've used in the past is called Clinical Measures, and it I'm not exactly sure what the price of the software is, but essentially it will calculate a cost savings for the healthcare system for every intervention that a pharmacist makes. So we've used that over the last several years. Recently, we have integrated, so our so Ballot Health uses Epic, and so we've been able to integrate more of an intervention tracking software called iVents. And kind of outfit it for our needs in the primary care setting. I think iVents is typically built out a little bit more for the hospital pharmacy setting. But we've been able to work with our IT folks to kind of cater that and customize that more for the primary care setting. So we've been excited to have something that's integrated a little bit better into our software. But if you don't have that capability, Clinical Measures has been a great web-based software to use to kind of help track what your interventions are, what kinds of interventions, and you can also track which providers, which payers, and things like that to kind of keep an eye on that and how things evolve over time. Can you go to the next slide? So here's the estimated cost savings that I mentioned. And so this software calculates that based on data that cost prevention data that they have in terms of, you know, drug interactions and prevention of allergies or prevention of, accumulation and renal failure or different things along those lines. A lot of the interventions that our pharmacists make are typically adding new medications, whether that be an ACE inhibitor or a statin or insulin, or really anything kind of in the primary care setting, or getting rid of medications that the patient may not need. And so that's kind of primarily where they come from. But we also do insulin dose adjustments, warfarin dose adjustments, and really anything that comes our way. So our primary care providers see infant to advanced age and any disease state in between. So our pharmacists tend to get questions about any of those disease states. So we do have a cardiovascular focus, but I would say we also answer questions and help navigate clinical medication questions about really any disease state. So our cost savings, if you kind of trend this out, typically it's about 1.5 to 2 million per year per pharmacist. So if you kind of track that based on how many pharmacists we have, that's where you're kind of seeing that growth as we've grown our team. I think that's probably, to be honest, a little bit overinflated based on how I've seen the calculations that they've put in there. But I usually say, to give us credit for maybe half of that. And I still think the return on investment is still very strong for supporting a clinical pharmacist in the primary care setting. Can you go to, oh, thank you. So now the Tennessee-based cardiovascular intervention. So I went back through all the interventions that we've made kind of since 2016 and pulled out the specific cardiovascular data and kind of found the number of interventions per year. And in 2021 and 2022, that was where we primarily expanded in the Tennessee market. And that was kind of alongside that Tennessee Heart Health Initiative. So that's why you're seeing that significant growth in the last 2 years, both in the number of interventions, but also the estimated cost savings. We also started a statin-based initiative around that same time as well, following payer data. So I think that's probably a shift that you're seeing kind of maybe more for statins and diabetes specifically in those last 2 years. And this is a little bit more detail about the software itself, and kind of those different types of interventions that our pharmacy team makes. And if you were kind of seeing a pie chart there, you would probably see that appropriate therapy, which is a really broad category, but essentially it means starting a new medication or getting rid of a medication that a patient no longer needs, makes up the majority, as well as dosing issues. And those tend to be renal dose adjustments, hepatic dose adjustments, insulin, and warfarin primarily. And then that other category um, is really, that could be anything. That could be patient education. That could be, we've done a lot with medication access and patient assistance program applications, and kind of assisting with office workflows and things like that too. So it's kind of hard to categorize those types of things, but we've kind of put it into this other category. And our internal data spreads it out a little bit more clearly defined than that. But I would say primarily that would be our medication access initiatives and patient education as well. So now you have kind of our total statin interventions over on the right, and patient assistance program applications for the state of Tennessee. And then that total estimated cost savings of 12 million for our for primary care based pharmacists and quality metrics pharmacists that are based out of the Tennessee market.
All right. Thank you so much, Brooklyn. It's really interesting to see that data, and I see a lot of successes in that data, whether you're looking at the trends up in interventions and cost savings, or if you're thinking about direct patient outcomes. And in a little bit, we will share an example patient that has benefited from these pharmacist interventions and the pharmacist physician collaboration in the team. But first, we wanted to make sure everyone has a chance to participate, discuss a little bit. So this is our first discussion question. And it is, what are best practices for team member integration into the clinical workflow? So whether we're thinking about your clinical pharmacist, your health coach, any other support staff or team member who has some value to bring to patient care, what are some best practices that we are seeing across participating member organizations? And I'm actually going to have Brooklyn kick off this discussion with some thoughts that she's shared with me, and then we'll open it up to the rest of the group.
Yeah, I guess I'll start a little bit more broad, and then maybe we can get into more of the details based on what everyone kind of wants to learn more about. I think as far as relationships, um, at least in my experience, so right now, unless when I started, I worked in 2 primary care offices, and I've expanded. Now I have 7, and I would say the biggest thing that I've learned over time is that there needs to be some degree of a face-to-face relationship building process with each provider. They need to know who they're working with, what that person, what their personality is like, or how they handle certain questions, or what that workflow is, kind of back and forth, and what that feedback mechanism is. And that communication has to go both ways. It can't just be that I send messages to the providers every time I see a problem, but they can't get a hold of me, or vice versa. I think it has to be that two-way communication. And there has to be at least some level of on the ground support that you can have those discussions of, how's it going? Is this, my providers always laugh at me because I've shortened it now, but in the beginning I would just do laps around the office and just say, on average, do I make your life better or worse? And they would say generally better. And now I just do thumbs up or thumbs down. Like, tell me, how am I doing? Is this making your practice better? Is this taking work off of you? Is this a service that you feel like is beneficial to your patients? And if not, how do we go back to the drawing board to make sure that this is supporting our providers in the best way possible? And I think one part of, not to skip over this, but one part of what's come out of that discussion with those providers is, especially as we navigate resources, because pharmacists' salaries are, a part of this equation. I think we've learned that providers need more support staff. And so we've been able to utilize pharmacy technicians more in the last year or two, in the primary care setting, kind of alongside the pharmacists and the providers. But that has been a game changer for our patients, for the pharmacy technicians, and for the providers as well, that they feel like they have that extra layer of support. But we do have that kind of structure in place for what types of questions go to a pharm tech versus a pharmacist versus back to that primary care provider. So I think that was really come from that face-to-face discussion and relationship with the providers to figure out, what do you need? And then figure out who's the best person to help fix that problem or help address those specific needs. Does that help us kind of a starting point, and then maybe take questions from there?
Yes, that's perfect. So we'd love to open it up now to see ideas that other participants on the call have, or if there's any specific questions about what's been shared so far. I currently can't see the rest of my control panel for Teams. I can only see who's speaking. So please feel free to just jump in, and then possibly maybe like Alicia or maybe Brooklyn, if you see a chat notification, feel free to call those out.
Yes, if you don't have access to like a microphone, yeah, feel free to put it in the chat, and then I can pass it along.
And truly, in the nature of open discussion, this as we mentioned, this does not have to be pharmacy specific, and also can go into other areas than what we've shared here. Truly, anything is game, because this is all about you all brainstorming and improving your practices.
So Brooklyn, I have a question. I'm trying to stop the echo.
Okay. I was like, I'm not sure I heard anything after the word question.
Okay. I'm gonna use chat.
Okay, so Brooklyn, Pat's question was, do you rely on technology to get notified of the patients your physician wants you to see?
That is a great question. And I think it depends on, I hate that answer. It depends. But I'll say that there's probably a few different buckets that I could categorize this in. So I have some providers right now who are new to the practice, or maybe new to primary care, and they've been specialists in other areas, and now they're kind of coming into primary care for the first time, so they're building their panels. And I would say in that way, I'm using technology to pull reports for them of all of their patients that have an A1C above 7, all their patients that have blood pressure that's outside of the, greater than 140 over 90, or maybe less than 90 over 60, to see if there's maybe any patients that need follow-up appointments with their providers. And then, it kind of sending that on to the front desk to get those patients scheduled, because they have room on their schedules, and they're trying to make sure that they're still building their panels, but not missing any patients that may fall between the cracks. And I always tell my providers, like, I always trust them as that first layer of, these patients just need to see their provider, and get their labs drawn and get their blood pressure checked and all of these types of things. And then I always kind of add that on the back end of, if when they come in to see their provider, they're seeing needs of, they can't afford their medications, or they're on 25 medications and they just can't keep track of all of them, then they consult me for it. So I think I usually do kind of lean on the primary care provider, or maybe a nurse practitioner in the office that may have a little bit of a lighter schedule, to get those patients in sooner, and then consult the pharmacist if needed. Based on the studies, on average, about 1 in every 8 patients could really benefit from a clinical pharmacist in that visit. So it hurts my feelings at sometimes, to say that not every patient needs me, but at the same time, I think that's how we're able to leverage pharmacists across multiple practices or across multiple providers, because a young patient who's not on any medication, or maybe just 1 or 2, wouldn't benefit from seeing me as much as maybe a more complicated, complex patient that's on 15 medications or more. So I lean on the providers a lot more to help drive that almost referral process, because they know their patients really well. They know who is struggling. They know who needs help with resources, needs help with just, access to medications or adherence techniques or different things like that. And they're really good at figuring out which patients are that want that extra layer of support versus maybe patients that wouldn't be as interested in that. Does that answer your question, or was that a little bit more about the EHR specifically? I would say if it is more maybe about the EHR specifically, we used to use Allscripts, and in 2020, when everything else in the world happened, we also switched our EHR, which was very stressful. I wouldn't recommend that. But we've switched to Epic, and it's opened up a lot of doors for us to integrate into different communication techniques across specialties. So right now, we have clinical pharmacists that work in our hospital systems that I can send them a secure chat right now and ask the infectious disease pharmacist, hey, what do you think about this antibiotic? And, maybe we should admit them to the hospital, or maybe we can manage it outpatient, and what would they recommend kind of as that bridge if the patient's hesitant to go to the hospital. So I think it has opened up those doors of integration of our system as a whole between primary care and other specialties, or primary care in the hospital system as well. We also use Teams for kind of interprofessional communication back and forth that may not be patient related. And Epic also has a really great patient list feature that you can build patient lists of all the patients that need to be on a statin, or all the patients that need to be seen in the next month or something like that. And you can easily kind of set yourself reminders to follow up with certain patients at certain points as well.
Brooklyn, Jennifer had a question as well. She said she was interested to see in your previous slide that dosing was one of the biggest savings. Could you share some insights about why this has had such a big impact with your teams and patients?
So if you compare dollar to dollar, the dose adjustment feature doesn't generate as much of a cost savings as adding or removing a medication. But I would say it's based on, for warfarin, preventing a GI bleed, or for insulin, preventing a hypoglycemia episode. So I think that cost savings attribution is probably around $1,000 to $1,500, which is, again, probably overinflated. But I think what we shoot for is a way to measure ourselves, as what's our rate of growth, and how do we kind of compare one year compared to the next, or one location compared to the next. So I think that cost savings, I'm not the one that calculated all of that, but I do think it probably is overinflated, but it does help give us a direction and a sense of what are the most crucial maybe interventions versus ones that may not be quite as may not affect the total cost of care as much as other interventions. But I would say preventing a GI bleed and hypoglycemia, especially with insulin dosing, is where those calculations came from.
Great. This is very informative. It's really neat to hear the interplay between all the ways that you're using technology to support your providers or your prescribers. And I really like the idea of the 1 in 8 patients, even though we might love for it to be 8 in 8 patients that need us. I think that really goes to show, prioritizing of resources, including, what you're bringing to the team, and finding the most effective ways to do that. So that gives some good food for thought on this process. Well, in the interest of time, if anyone else has other questions, please continue to put those in the chat or just speak up. But I'm really excited for our next slide, which is an example patient. Let me see if I can get this working again. There we go. And Brooklyn is going to share a little bit about this patient case.
Sure. So I love this little guy. He did not have insurance. He is self-employed as a barber, which he will tell you as soon as he walks in the door. That he's always offering to cut people's hair, which I think is adorable. But when I met him the first time, he was struggling managing his diabetes, and he was on very high doses of insulin, which is why the provider sent him over to me to kind of figure out, okay, what do we do? 140 units a day of long-acting insulin, and his A1C still isn't budging. And he's a very motivated patient. He wants to, eat better. He wants to do everything right. He just doesn't always know how, and he can't afford all of his medications. So specifically, Tresiba and Brilinta were the ones that at that time he was struggling with the most. He had just had an InSTEMI, and so the Brilinta, aspirin, atorvastatin, and I think losartan were all brand new for him. At that time, kind of after he was discharged from the hospital. So he comes to me and he was just like, I don't know what I'm going to do. I can't afford this. And, I don't know what my options are. And so we have resources on our team to help patients apply for different insurance options and things like that for medical insurance. But we also have options for patient assistance as well. So our pharmacy technicians fill out the paperwork to do patient assistance options through Novo Nordisk or different drug companies. So through that, we were able to get him Tresiba completely covered. We also started Ozempic, not at that dose, 0.25, if anybody's paying attention, to specific doses. And we were able to get the Brilinta for free through patient assistance as well. So through that, he was able to lose almost 20 pounds. And I also identified that the Bematone could interact with that Brilinta and aspirin and potentially cause a GI bleed. So that was something that we were able to get rid of and educate him on using Tylenol or other options for osteoarthritis. We were also able to lower his blood pressure. So that was through some diet education that we did. He started exercising a little bit more. I also found a study saying that telmisartan may be just slightly stronger than losartan. So we switched him over to that, and the cost wasn't too significantly different between the two. And that may have been part of that as well. But obviously diet and exercise can make a big difference in terms of blood pressure control. And his A1C is down by 0.4. Don't judge yet. We had just gone up to that 1 milligram of Ozempic, so I think it's going to come down even more than that. But at that time, at least on the 0.25 and the 0.5, it had come down by 0.4%. And having that Ozempic on board could obviously lower his cardiovascular risk in the future. So I think we were able to move a lot of things in the right direction for him, but also help him with medication access as well. So hopefully that's helpful just to kind of see a big picture, like what does this look like in the office? So I saw him in the office probably since 2020. I've probably seen him 5 or 6 different times, and I usually see him alongside his provider. And so the nurse comes in, it does vitals and everything the way a standard visit would go. I go in and make sure, to update all the medications, check for drug interactions, check for omissions or errors or anything along those lines, make sure access is addressed. Adherence issues and everything, and then kind of tee that up to that provider during that visit to say, here's what their blood sugar readings are, here's what they're taking, here's what their insulin doses are. I'm thinking about making this adjustment, and what do you think about this? And having that be a face-to-face conversation that happens at the time of the visit. And so this provider has a large panel, about 1,200 patients, and he sees probably 25 to 26 patients a day. So the way he sees it is, I can save him time of, I may spend 20 minutes in the room with a patient like this, and then he can go in and kind of tie up loose ends and address, any new diagnostic things that might be happening, because I'm very adamant I cannot diagnose anything, and I'm not going to pretend to. I definitely will collect all of the relevant information, hand that off to the provider, and say, I don't know what's causing the shortness of breath. I don't know what's causing this, but this is what the patient told me. They may ask you about this when you go in the room. So I think that may help to just kind of clarify what the role could be and what that relationship could look like. out of our 10 clinical pharmacists that we have, that may look a little bit different in other offices, that may be face-to-face, that may be some virtual telehealth options, kind of in between. But I would say that regular feedback from the provider on how they like things done, and kind of what they want that workflow is to me is the biggest key to success. And just making sure that, and I always tell my pharmacy students this, so I usually have them on rotation with me, and I say, as soon as you make them late to one kid's soccer game, you have lost. Like, you need to make sure that what you're adding is truly a value added for the patient, for the provider, and for the office. So if we're spending 2 hours in the room and now that provider has to stay until 7 o'clock tonight, this is not the best option for them. So some of those visits that may take a little bit longer, I may put them on my schedule individually, as like, okay, here are the issues that we're going to address today, and then come back next week and let's sit down and really dive in and get you started on that continuous glucose monitor, get you, more of that in-depth diabetes education or smoking cessation follow-up or whatever the case may be. So I can do kind of that shared visit model, that it is part of that provider visit, or more of an independent visit as well, if it is kind of more of that time-intensive patient education type visit, where the diagnosis is already very clear, but they may just need a little bit more of that education and support in a follow-up visit.
Perfect. Thank you so much for sharing that. It's a great story, great outcomes for this patient, and so much goes into this from the pharmacist supporting the team and helping this patient. So I think patient stories are really powerful for sharing the impact of different team members. But I was curious, and I wanted to just briefly share with the group, is there any published evidence, from larger groups of patients that show benefit, and particularly with the angle of patient assistance programs for medication access. And I would say, yes, there is evidence for that. But it's not one or the other. It's not simply getting medication access for patients. That is huge and often critical for them to be able to use their medications as prescribed. But also, the therapy optimization piece and all the different interventions that Brooklyn talked about that her team did is also part of that. And together, very powerful for better clinical outcomes. So one example, I pulled this table out of a recent publication, and this was really just on a small number of patients, but it is a collective group. And they put patients through phases of regular, just usual care, adding on free medications for their chronic disease states, and then free medications plus pharmacist management, which would be that kind of next level interventions like Brooklyn talked about. And so for 3 measures of chronic disease states, systolic blood pressure, A1C, and blood glucose, you can see the average values these patients started out with on usual care. And then you can start to see some decreases in some areas more than others, just simply by getting free medication. So medication access is very important to this. But then you can see there's even more significant drops. So for example, average systolic blood pressure from 150 to 125 when you add in pharmacist management with the free medication access. A1C average 11.3 to 6.4, and blood glucose point of care from 303 to 138. And so this, I think, goes to show both of these considerations are really important to patient outcomes, and it's best to have both available if possible in your clinic setting. There's also been systematic reviews that show patient assistance program enrollment plus other medication services from an expert like a pharmacist do lead to better disease indicators for chronic diseases. So we're happy to share those citations with you all if you want to explore them in further detail. But that brings us to kind of our final discussion point. We'd love to know what others on the call are seeing or experiencing in their settings. with the question, how are you leveraging team members if you are? And it's okay if you're not, it's all about learning. But if you're leveraging team members within your clinic workflow to ensure patients can access their prescribed medications. And Brooklyn already touched a little bit on the way that they're achieving that at Valid is this really neat model of including pharmacy technicians on the team, which is not necessarily a profession that we always think of in the clinical setting, but certainly there's obviously a lot of benefit to having them in the team to do this patient assistance program application paperwork. So with that question in mind, I'm going to open it back up to the group. Brooklyn, if there's anything else you'd like to add about your workflow also, feel free to chime in. But I'm going to actually pull the slides off so I can also see the whole set of participants while we talk about this. All right, and Alicia, Jennifer, or Pat, I might ask you to help me out if you know what other health systems or clinics are represented today. If there's any in particular that you see, we'd love to know how they're going about patient assistance workflows in their settings.
Hey guys, this is Alex. I'm the clinical pharmacist or pharmacy manager over at Christ Community in Memphis. So we actually use pharmacy techs as well. But we have clinical pharm techs that we're kind of piloting with med histories. So we have like a transitions of care kind of model that we're trying to start. But we're also doing it with patient assistance. So patient assistance programs, PAs. We have nurses that historically did it, and we're kind of trying to take some burdens away from some of our nursing staff. So we've kind of procured that with the pharmacy team. And then they've also been resources for us for timeliness of filling. So we have on-site pharmacies. So if they're doing the med histories, then they kind of triage what refills they need on the front end. If they have refills ready in the pharmacy, that kind of breaks down the miscommunication that they quote unquote don't have refills, so they can get them ready during the visit, so that way they can get the medicine on the way out. And if they do need pertinent refills, I know that at the very beginning, so I can go ahead and send them in unless we're going to make some pertinent changes. So we're using technicians in a similar type of model, maybe different based on certain settings. And that's how we're kind of using those technicians to also pull away from the burden of some other, healthcare workers as well. But we also have a smaller, but yet still influential clinical pharmacy team. There's technically 3.5 of us, 1 part-time and 3 full-time, including myself, between our 7 clinics.
Thank you for sharing. That's really interesting to hear and neat to hear you're also taking the pharmacy technician route. But we always see, some variation between different systems in how you're doing that, how you're utilizing those team members. So that's great to hear. Any others like to share what you're doing for patient assistance?
Thanks, Alex, for speaking up. I was actually, I saw you were on the call and I was going to ask what y'all are doing. I do know, I don't see anybody on the call from Regional 1, well, other than Dr. Bailey, who does clinic work there. But I know that a couple of the practices that are participating are also using the pharmacy text. And I know one of the ways they do it is take a lot of the incoming calls from patients about medications to take that off the nurses. And that's been a huge help for them.
I also see that we have Susan Butterworth on the call, and we had been interested, Susan, in asking you if you saw any parallels or just kind of contrast between what we're talking about and what you see from your health coaching team member perspective. And apologies, I couldn't see the list of names earlier. I would have called on you earlier, but just wondering if you had any thoughts relating to these strategies you're hearing about. Susan might be in a place where she can't unmute, but if she is able to, we'll definitely welcome that perspective as well.
I had more of a clarifying question. Just obviously, our patient populations are slightly different, given where you all are in Eastern Tennessee and versus West Tennessee, but um, we still struggle with similar things based on rural areas and patient access, obviously. Um, and more so for me, you guys mentioned earlier that you have a pretty large breadth of coverage. I think you said you cover 7 clinics. And I think I originally started covering 7, and I immediately said, based on all the clinical work I've been doing, I need to have some assistance. So, how do you all manage your clinical workload? And do you all see like patients based off referral, similar to how we do here? And if so, what do your clinic visits look like and things like that, just so we can kind of, emulate if needed?
That is a great question. And I don't love saying the phrase 7 clicks because I think everybody's like, whoa. Um, and I will say that it just so happens in this market that I'm in, that a lot of those clinics are actually very small. So they're a little bit more spread out, where they may have 1 or 2 providers. So it's probably better for me to use the provider ratio. So I went from about 1 to 8. Maybe 8 to 10 kind of in the first few years, and now I have 22. But the difference is probably, I would say maybe not quite half, maybe 40% of them are newer to the system, still building their panels. And I don't know. I think because the training is a little bit different. They're a little bit younger. That they've graduated maybe in the last 5 years or so. I think they utilize me in different ways than my more seasoned providers that may lean on me a little bit more heavily, from a time management standpoint, just because their panels are so large and they just can't see every single one. So I don't know if that's really helpful, but I also think around that same time frame when I said I was willing to expand what that number is when I requested the farm tech. And I do think that's a huge piece of job satisfaction. And also supporting the practices and the ways and the areas that they need it, because I think prior authorizations, patient assistance, were a huge part of what my initial ask was, as kind of the first pharmacy support person in the office. And once we started realizing like the providers don't care who does the work as long as the work gets done and it gets done right and the patient's taken care of. I think I felt guilty at first saying, I think I'm going to let the farm tech do that, and fill out the patient assistance paperwork or do the prior authorizations. At first, I think that was hard for me to let go of. But once I realized that if you have the right pharmacy technician, they can really knock it out of the park and they love it. They enjoy it. They love finding coupon cards. They love enrolling in patient assistance and getting those patients, free access to medications. So I think from a job satisfaction standpoint, from their standpoint, they are happier being able to provide this extra layer of care. But I also think it helps us spread out resources a little bit more carefully. So we also merged around that same time as well. So we went from 26 primary care offices to 45. And that's when our boss said, I'd love to have a pharmacist in every office, but there's no way we're going to be able to do 45. And so how do we look at this a little bit differently? At how do we use everybody to the top of their license? And I think that was where that provider ratio changed a little bit. And maybe the dynamic between me and the providers changed a little bit, but we also had that extra farm tech support that helped keep the workload manageable. It was probably a really long answer to what your question was, but hopefully that was helpful.
Yeah, it definitely was. I think for me in terms of replication, it definitely is hard to emulate 7 into 45 different clinics, of course, but um I think on our end, the things that we've been able to recognize is, those key areas of improvement of exactly things you hit on earlier. And forgive me, I had to patient care things every now and then during the call, so had to step away for a moment. But looking at the soft dollars, we've had tons of soft dollar savings on our end too, of course. And I may have, like I said, I may have stepped away and missed. Is there any type of hard dollar things that you guys are doing as well? And if so, I'd love to dive into that with you guys later on, maybe off call. But we're currently looking into like the whole credentialing process. We've been credentialed as providers through like TennCare, so billing mechanisms and all that kind of thing. Unfortunately, the loopholes we struggle with are we're a federally qualified health center, so we can't do certain things like RPM and things like that because it's just not part of that classification. But trying to find ways to obviously fund more clinical pharmacy technicians. I think we've already seen some great success in the couple that we have. And I can definitely agree with you. They love doing it because they are on the, we kind of split them between clinical and pharmacy coverage based on our availability. But when they're in the clinic, they are just overwhelmingly pleased with face-to-face interactions, that there's some continuity of care for them, I think, because they get to see the patients that they've filled their prescriptions for as well. So I think the patients enjoy that continuity. They like to have the same pharmacy tech, same pharmacist, and same doctor if needed, right? So I think for us, I wanted to make sure that if you guys are doing something that's exemplary based on all the data that I saw today, I'd love to see if there's something we can be doing better here.
I would love to chat more offline as far as like those specifics. But I think one piece, at least, of how our organization is structured. So all of our pharmacy team comes out of the PCMH budget, and we really, I guess, the closest thing I could say to hard dollars would be more of our STAR metrics. So there are certain metrics that our pharmacy team is primarily responsible for, and we're kind of measured based on how we do on those STAR ratings, if that makes sense. So I don't know exactly how that works in the FQHC world, but at least for our department, that has been more of that cost justification than just the software that we use that shows how many interventions we made is actually watching where those STAR measures are going.
Okay, great. Yeah, we're doing that exact same thing as well. I think you guys saw it and we've seen it too. The better measures you see, obviously the more reimbursement you can make. So yeah, great.
So there's been a couple things in the chat. There's a great patient video, patient story video from the network. If anyone hasn't seen that yet, highly recommend. Another story of a pharmacist's impact on a patient, and that one's out of Regional 1 Health, and so great view. And then Jennifer had a question. Do teams generally develop standing orders in their EHR for the referrals for pharmacist assistants or possibly a health coach? So thinking about, is that a way that workflow can be established with this?
So in our system, we have that built out that they can put in kind of a generic referral to a pharmacist. And if the providers don't have that kind of face-to-face relationship, the questions could be anywhere. Sometimes it's they can't afford their medicine. Sometimes it's, can somebody do a complicated medication review or meet with this patient and sit down with them and go through all of their medications and everything. And yes, all those things are true. A pharmacist can help with all of those, but I think it's created a lot of extra layers on the back end of, well, a pharm tech could handle this, or maybe we could get this in place to be able to help that patient. And so at least what's worked for us has kind of been more of that one person for kind of each market, and so instead of a kind of a generic in-basket pool, those providers would kind of lean on that one pharmacist, in that way there's a little bit more of a feedback mechanism of what we can and cannot do. So in the state of Tennessee, we have to have a collaborative practice agreement to be able to change medications or send prescriptions in or anything along those lines. And I think having more of a generic referral process, sometimes the lines get a little bit blurry of what we're able to do and what we're able to help with versus where the lines get sent kind of back to the provider to say, here are some recommendations, but I can't do anything, but I explain to the patient, here are different medication options to consider. So we've kind of done a little bit of both with the kind of standing orders for referrals, and then a little bit more of a maybe more integrated face-to-face model, where I'm just doing laps around the office to say which patients, it could benefit from me seeing them. And I don't know how many times I've been stopped coming out of the restroom, with just a, hey, I saw this patient, like, can you talk to them about this or anything along those lines? So I'm not sure if that answers your question very well, but I would say, at least in our experience, the kind of standing order model, unless it's really specific of initial diabetes education or something that it's a very clear cut, this is what I want, and then that handoff is pretty straightforward. I think we've had a harder time with what that handoff looks like, back and forth from the provider to the pharmacist and then back.
Great.
Yes, I do meet my smartwatch goals. I try to walk a mile every day.
Sounds like pretty easy to do with everything that you've got going on in the clinic. This is great. Anyone else have any questions, comments on anything that's come up today?
The only question I have is, how do you approach patients who may not be as open to seeing you, before the provider, that they've got that relationship with their providers, basically, and want to talk to them about everything. How do you develop that relationship with them?
So again, with it's kind of the warm handoff. So I think it's building the relationships with the providers that then they trust me enough that they bring me into the room themselves and say, here's Brooklyn. I want her to talk to you about this, this, and this. This is what we've talked about, but she's going to help you with these things. And I think that helps. I've never had a patient refuse whenever the provider specifically said, here is my pharmacist that I want you to talk to. If I just randomly go into rooms, yeah, I get a lot of like, why are you here? And I don't really I don't want to use your pharmacy. And I'm like, I don't have a pharmacy. It's just me in this clinic. And it's a little bit trickier just because patients don't always understand it. But I think having those, and I'll say this too. So I've been doing this almost 10 years. And I would say for the first 3, I think I felt like I had to self-advocate all the time. I felt like I had to go into every room and explain to patients what I did. And I think in the last couple of years, I've started to lean on my providers a lot more to say they know who needs me and who doesn't. And when they know somebody needs me, they're going to help with that warm handoff to introduce me to that patient, or have their nurse introduce me to the patient, or whatever the case may be. And I think I probably see fewer patients, but the ones I do see are definitely ones that I know need that extra layer of support. And it's very clear that support needs to be a pharmacy person. Sometimes I have to kind of refer back and forth to the pharm tech of like, okay, they can't afford these things. Can you help them with that? But then I'm going to do these things. But I do think that the providers have been a lot better at choosing the right patient than a list that comes from a spreadsheet or payer data, because I think there has to be that human connection of where is this patient in their life, and sometimes providers will look at a list like that, and I'll just show them the list and say, here's your 20 patients with an A1C over 7. What do you want me to do with it? And they'll say, that one's wife just died last week. Let's wait. This one, is just went into hospice. Like, let's, if they call us, let's help them. But like, this may not be the time to talk about statins. And so they're a lot better than I am at piecing those things together, that I may not have that context because I don't know all of their patients that well.
Thank you.
Well, thank you so much, everyone. And thanks for having us on to talk about this today. And again, truly thanks to Brooklyn for being willing to just share all of these ideas, all this great work that you're doing, and go with the flow on it. I wanted to leave the group with one interesting tidbit. When I was looking for literature on this topic, I actually found a couple published studies showing benefits of collaboration between clinic pharmacists and health coaches. So there's actually some models of that out there. And so that's just an interesting thought. Whichever toolkit your practice might be using right now, down the road, there's opportunities you might be able to even, kind of stack benefit from these different team members, and that has been done. So just something for the road. But with that, Alicia, I'll hand it back if there's any last things you have for the group.
Thank you, Carrie Lynn, and thank you, Brooklyn, as well. That was very enlightening, and I mean, I learned quite a bit today because I'm not a clinical person, so it's nice to see and hear from you all how you're working through the issues that you've come across and how you develop those relationships. But I don't have any other questions or comments, and I just appreciate everybody joining, and we'll see you next time.
Thank you,
Thank
guys.
you.
Bye.